We recently published our results from a head-to-head comparison with a next-generation sequencing-based approach to identify gains and losses, as well as IgH translocations in multiple myeloma. This study was conducted head-to-head with standard of care FISH and cytogenetics. At our institution, we use myeloma FISH panel as well as SNP array. So we compared almost 200 patients' standard of care results with this next generation sequencing-based assay that's called MyType. What we show is that the sensitivity and the specificity is more than 99% for the detection both of gains and losses as well as IgH translocations when we use the standard of care as the denominator. If you look in addition to what you can find with SNP array and FISH and cytogenetic approaches, you actually can find additional alterations with this new technology. I think also very importantly, because this is a DNA-based assay, you will have information on somatic status for mutations. And I think in particular, when it comes to, for example, P53 and other tumor suppressor genes, you now have the ability to study potential bi-allelic inactivation. We saw that about 30 or so patients had a 17p deletion in our study, and around half of those patients had also a P53 mutation in the other allele. So half of the patients only had a deletion 17p and no P53 mutation on the other allele. I think this is very, very important clinically, and thinking about what was shown about 12 months ago by Walker et al., they showed that patients with only a 17p deletion have the same prognosis as patients who do not have a 17p deletion. While patients who have a 17p deletion partnered with a mutation of P53, those are the ones who have really poor prognosis. So in a nutshell, I think our study here, using clinical samples from patients with myeloma, we are able to show that with a next generation sequencing-based assay, you can capture the exact same information as you do with FISH and cytogenetics and even SNP array. You can get rid of all technology, and on top of that, you are now able to also determine somatic mutational status in one assay, and you can actually assign patients with high risk with much better precision. And I think this is really how the field will have to move forward in the near future.